This is a C. Jason podcast, and I'm Sylvia Titan, nephrologist at Mayo Clinic in Rochester, Minnesota. I'm happy to share here the results of an investigation we did, which was published in January 2025, and I would like to thank C. Jason for this opportunity. To put it into context, GFR estimation is challenging and a well-known problem for nephrologists. Certain populations may be at particular risk of poor performance of estimated GFR, as is the case of people with cancer, who may have a high frequency of confounders of the association between endogenous filtration markers and GFR. Having a worse precision in assessment of kidney function has significant implications in the clinical care of these patients, starting from the diagnosis of kidney disease, but expanding into eligibility for treatment and trials, assessment of risk of side effects of procedures and treatments, prognostication, and very importantly, drug dosing. Recently, the American Society of Onconephrology did an extensive review of prior studies, highlighting the need for novel studies and identifying areas of gaps, such as the population with hematological cancer. In our study, we investigated the performance of several eGFRs in comparison to measured GFR in people with cancer. We tested the most recent race-free CKD-EPI and AKFC equations, along with Cockcroft-Gault, which is still used by oncologists and pharmacists. We used a cohort of patients retrieved from Mayo Clinic EHR, composed of patients who had urinary iotalamate study done for clinical reasons, along with available creatinine and cystatin C. We define cancer as the presence of ICD codes for cancer up to 2 years before the measured GFR date, and after some cleaning, we ended up with a cohort of 1,145 patients, being about 40% cases of hematological cancer and 6% of solid cancer. Our results show that among all equations, the combined creatinine cystatin C equations provided the best performance, with small bias and higher precision compared to creatinine only or cystatin C only equations. Importantly, this was true for people with solid and hematological cancers, fulfilling the gap highlighted by the American Society of Onconephrology. Our analysis also revealed that the Cockcroft-Gault equation had the worst precision, with 30% of people with errors above 30%, and that the cystatin C-CKD-EPI equation was the most biased, prone to underestimation of measured GFR. Overall, the CKD-EPI and AKFC equations had similar performances, suggesting good convergence between them. Main strengths of our study were the large sample size, the stratification for solid and hematological cancer, and the use of standardized assays. The main limitation was the likely presence of selection bias in the study population. First, our cohort was derived from a large tertiary hospital, so likely to have higher frequency of complex cases. Second, measured GFR was not done systematically, but rather based on clinical indication or according to protocols in specialized clinics. We performed sensitivity analysis to address these biases, and they showed similar findings, which was overall reassuring for our conclusions. In the paper, we also showed hypothetical scenarios of the impact of differences in GFR assessment when computing drug dosing. For example, with carboplatin, creatinine-only or cystatin C-only equations would yield 24 to 29% of people receiving a dose 20% higher or lower than computed by measured GFR, while the combined creatinine C equation reduced this number to 17 or 18%, so nearly 40% less. However, these hypothetical scenarios assume that measured GFR is better for drug dosing, an assumption that remains to be proved, and certainly an important research topic for the nephrology community to expand on. In summary, our results give support for the preferential use of the combined creatinine cystatin C equations, CKD-EPI or AKFC, when eGFR is being used on people with cancer, converging with recent recommendations by the American Society of Onconephrology. Thank you.
This podcast is copyrighted by the American Society of Nephrology. All rights reserved. All content in this podcast is for informational purposes only and is not intended to be medical advice. This podcast should not be used in a medical emergency or for the diagnosis or treatment of any medical condition. Please consult your doctor or other qualified healthcare professional if you have any questions about any medical condition or before taking any drug, changing your diet, or commencing or discontinuing any course of treatment. Thank you for listening to this podcast from the American Society of Nephrology.